Thank you, Thomas, and welcome everyone. My name is Abhilash, and I am thrilled to host this conversation today on Datadogs, the future of healthcare in the age of AI, with some really incredible practitioners in India and in Kenya. We have with us Shashwat Srivastava, who's with the Clinton Health Access Initiative, Sania Pawar, who's also with the Clinton Health Access Initiative, and Fadila Yusuf, who is a healthcare practitioner in Nairobi, Kenya. And I'm going to be kind of talking over the next 1 hour and with them to get a sense of how they're seeing AI being used in the workplace. So I want to begin with just a brief round of introductions. Shashwat is, he currently leads the Clinton Health Access Initiative's India tuberculosis programs, which is looking at finding active cases across multiple states. And we'll hear more about that in a minute. In his professional journey, for over 13 years, he has worked with the Tata Trusts, the Confederation of Indian Industry, and the Standard Chartered Bank. He has held multiple roles in program design, large-scale implementation, policy and advocacy across multiple domains in livelihoods, health and nutrition, skilling, and education. Sania Pawar has been a civic tech scholar at Equitech Futures and currently works at the Clinton Health Access Initiative, again, working with the tuberculosis program. And Fadila Yusuf was from the first cohort of Equitech scholars and is a doctor, is trained as a doctor in Kenya, and she's based out of Nairobi. And Fadila, if you're in a place where you can turn on your videos, it'll be great to be able to see you. I want to get this conversation started with you, Shashwat, in sort of getting your take on how you are seeing AI transform healthcare in the Indian context, particularly your work on tuberculosis in India.
Thanks, Abhilash, for the introduction, and thanks, guys, for joining in. And thanks for joining in across different time zones, and that's always much appreciated. So, if you'd allow me to put the lens of the public health to this, and that's where the game kind of changes. Right? While the private healthcare ecosystem has had the advent of AI from fairly early on, has had the bandwidth, the energy, and the resources to tap into that pretty early on. Public health in India is seeing this journey in its nascency, if I may call it. While I think there are islands of excellence around this, but from purely a public health viewpoint, the AI is both to some people's eyes the unknown devil, and in some who've had the opportunity to work with it for some time. And when I say some time, it's definitely a quarter of a decade, not longer. They are starting to see the benefits of it, but again, the stage of nascency, time will tell how this pans out. And just to give in context of where I'm coming from is at Chai India, one of the projects both Sania and I are part of, what we essentially do is use the help of AI to go down into low access, highly marginalized, vulnerable population segments, rural India, and identify TB cases, right? But why is that so different a problem statement to arise now? It's always been there, right? It's the need statement has become stronger, if I may put it that way. the need felt was always there. The statement has become more stronger. Uh, and from the point of view of why do we need it? I'll always circle back to the point that AI doesn't need to be needlessly part of the public health system unless and unless there's a very strong proposition for it. And in the disease vertical that we work in, most certainly tuberculosis, um, it does bring AI front and center to problem solving. Um, yeah, in itself. Why so? We are using X-rays and we are offering X-rays largely because a large percentage of our population, Indian population, and enough evidence suggests do not exhibit any symptoms for tuberculosis. Um, and therefore, that begs us to reconsider that how are we going to look at all of this huge chunk? And when you look at it from an Indian perspective, the percentages uh, large lead to large absolute numbers. So those numbers in itself are fairly scary. And therefore, we offer an X-ray to make sure that we are able to read images of healthy lungs versus abnormal X-rays and find, let's say, some chest abnormalities here and there. And that seems like a fairly simple thing to do. But why hasn't it gone thus far? Sure, X-rays have evolved to going from size of half a block of a building to one room of a building to now things you can carry around hands. Certainly so. But what has really proven AI to be of use is lack of manpower at the absolute grassroots level public health system in India. And when I say so, it's not only the lack of resources, but also the lack of capacity of the resources wherever available. Essentially, talks about uh, unskilled medical staff be able to diagnose, triage, and find high risk populations. And secondly, uh, even if they're not present, what do you do? That's not just enough for the public health to look at. So therefore, the case for AI was very strong in this disease vertical, and it is for a few others as well. But while I guess we can probably dig uh, deeper into this topic, so I'll restrict my opinions to how the TB space works. And the third piece why AI becomes very appropriate is access in terms of uh, in public health as it is in most um, when you look at a cost benefit of any social good, right? The willingness to pay often in terms of both money and time is is a very is a very tricky piece, especially when it comes to rural India, which means is a surface offering, even if it's free, if it takes as long as it would for them to be spending half a day in a hospital, they'd say, I don't have a need for it. Or alternatively, if they have to, if you were to kind of put a dollar value of their time in terms of lost wages and access that service, that is also something that's not acceptable. And again, just kind of reiterating this, that the segment of population the program works with it is that's how most part of rural India is. And therefore, these challenges are very real. We've had to adapt in a way that we bring back a human-centered approach to this rather than what the AI is supposed to do. That's not how we're looking at it, right? It's what the end beneficiary needs out of it. So that's how I guess my 3 points on why AI is relevant and more so why AI has been very relevant to us. So I'll just take a pause here. Happy to hear your thoughts on this. Thank you.
Yeah, like I really like the way in which you kind of framed it as sort of saying, in the case in the public health sector, it is not, a tool looking for a problem. There's a very specific problem, and it seems like there are three broad problems in public health space, right? One is just the lack of skilled professionals who can do the right diagnostics, the cost of diagnostics itself, which, by the way, is not just expensive in developing countries. It's also expensive here in the United States, and the cost of diagnostics is something that everyone worries about because, if you can actually diagnose something early on, you can not only prevent things getting worse for the patient, but in the case of tuberculosis, it becomes a critical public health situation because you can quarantine people and prevent more people from getting it away. So the cost of diagnosis has very profound public health implications, which is something we saw in the kind of COVID case as well, right? I mean, the one of the critical ways policy focus in public health during COVID was to bring down the cost of tests, because the moment you had low cost tests, you could then identify people and sort of quarantine them. And that's, I think, a very important thing about AI, the fact that AI really brings down the cost of diagnosis is important. And the final thing that I think a lot of people in developed countries, or maybe in cities in India, or high-income patients in India might not get, is healthcare and kind of wages are deeply related in some ways, right? The fact that a lot of people are unwilling to go to a hospital for a cough or even for relatively serious symptoms, purely because they are worried about lost wages, because you don't have the kind of social security or the social safety net that you have in other parts of the world. And so that again means that you cannot rely on the kind of point of care being the only place where you diagnose diseases. You kind of need to take the kind of point of diagnosis separate from the point of care in some ways. And what's interesting about Chai's approach is to kind of think about the point of diagnosis as being separate from the point of care. And I want to go to Sanya because, Sanya, you've worked on the logistics of how this kind of works out. And if you can talk a little bit about how this works in practice, right? So talk to us a little bit about these X-ray machines that you are setting up in kind of community centers and villages, and the kind of responses you get and the kind of challenges you have when you're engaging with people with these tools.
Yeah, so I think what Shashwat explained at a macro level was how AI is solving and addressing the multiple problems at different levels, starting from the community, the lowest level, and then coming to a systematic level as well. So for now, the project, which through our intervention, we are leveraging AI in the space of diagnosis. But what also brings in terms of the specific areas which are not yet a part of the project, but I feel that AI stands at a very strong intersection and junction for these four broad core areas. One is diagnosis, yes, what we are doing through our project. The second is mortality risk assessment, right? So as and when we gather more and more data points, as and when we gather more data through the project we are doing, and not just this, but across the globe, we will be able, there is a possibility of building a risk assessment, which is more like a prediction model. And AI and ML has that capacity and the capability to do so. The third core domain is obviously your disease outbreak prediction and surveillance, which we had seen during the time of COVID-19, how the prior data and the new data points coming in was used to predict the outbreak and also keep a surveillance model on. And the fourth broad core domain, and I think our project is definitely contributing to that, is at a systematic level, which is your health policy and planning. So what we do on ground, what the data we gather across different demographics, different geographical settings, is adding value and is informing the systematics approach towards health policy and planning. So in terms of the project we are doing, very much sets into the picture of the various challenges we discussed, the ones Shashwat mentioned, the ones you highlighted, and they can be seen very, very explicitly as tangible problems on the ground. And we can also see the impact that AI is bringing. So the way we do about it is that we choose a specific geography, we choose a specific spot, and there is a lot of planning and processing behind choosing that spot, which comes from multiple parameters, that whether this particular location has more TB notification rate, whether this has more vulnerable population, is it at a higher risk as compared to another location. So once that location is decided, the field team, which consists of obviously a lead who sort of operationalizes the whole camp, there is a person who mobilizes the community a day before the camp, and then there is a radiographer who operates this whole setup and the machine. The team reaches the spot where the camp is set up. The way the camp is set up is not advertised and promoted as a tuberculosis camp. It's a general health checkup camp, and that's how we put it forward. And this has come from a pure reasoning of the stigma attached to tuberculosis in the community, and especially in the rural communities. So the way we sensitize this is a general health camp, and we provide free services starting from basic tests such as your height and weight. We add hypertension, which is BP, we add diabetes, random blood sugar, and then in a few cases, we have hemoglobin and HIV as well. So these basic tests are one pure free offering we provide to every beneficiary who is entering our camp. All of this data and information we record from end to end, which is like in process of an assembly line process, is being recorded on an information system, which is a product of Chai India itself. So we are working on this information system which records all of this. So this is how technology from point one is helping us record the information, which is then linked to AI, and then we get the output again through a technological process. Post these basic tests, we have a symptomatic and vulnerable screening, as Shashwat was mentioning. We understand whether the patient is having any TB related symptoms, and then we evaluate them across multiple and multitude of risk factors, making sure that we're not missing out on any. There's a lot of research and study gone behind finalizing this set of risk factors and vulnerability factors to ensure that we are covering the right population. Post this screening is when we send the beneficiary for the CXR, which is your handheld X-ray machine, the ultra portable X-ray machine, which sort of screens. So it screens for your chest X-ray, and this is what is enabled with CAD, which is a computer-aided detection software, and this is enabled with the AI interpretation tool at the back end. When the X-ray is taken, within 1 minute, we get the AI suggestive result on the ground. And this is where, as we discussed, how the need of radiologists and medical officers at every point in a remote terrain, in a peripheral level is supplanted. So this is the point where that AI result gives us the solution and addresses the problem of scarcity of HR, scarcity of medical professionals on ground. And that AI result gives us the information for the next process, which is whether we need to send the patient for confirmatory, microbiological confirmatory test or not. So this whole process and this whole algorithm has been set and has been informed by multiple literatures, medical research of how and what needs to be done. And post the confirmatory diagnosis is when we put the patient on treatment. So this is happening for each and every beneficiary who is entering the camp. And this is how the chest X-ray is added as a layer, is added as a detection tool before the confirmatory diagnosis. So yeah, this is how the process goes on.
So this kind of, thinking about the pipeline of diagnosis, all the way from people coming to the camp to whether or not they need to get support for or treatment for TB, it's very clear that there's this critical point of getting an X-ray and being able to come up with whether or not this person is at high risk or has high likelihood of having TB. Typically, I've had like TB. Anyone who has to leave India has to go through a TB test, and so I've had that happen. And the process of going and getting an X-ray and having a doctor sign off on whether or not you have TB can be anywhere from a 6-hour to a day-long affair. And it seems like the value add of AI is really to reduce that diagnosis pipeline, both in terms of cost and time. So that's very clear as to what the value of AI in this whole chain of diagnosis is. I want to focus a little bit on the various stakeholders involved in this diagnosis chain, right? So you have the patient, obviously, which is the most important stakeholder in this situation. You have CHAI or the allied partner, government partners, and then you have the community where you're working on it. Like in any public health setting, you have to work with the community because there might be norms involved in detection of certain types of diseases and how those norms might affect both you, the medical service provider, or the patient who is coming in. So I'm wondering what kind of tensions or responses you have seen. It's very clear that you as a medical service provider or as a person coming in with the technology recognize the value of the technology. I'm wondering how it has been for the other stakeholders in this ecosystem. And this is a question for both Sanya and Shashwat. Like what are the kind of tensions you've seen in this process?
Sanya, why don't you answer? I'll add on.
Yeah. So in terms of stakeholders, I think the involvement of stakeholders is very diverse, and I believe it's a huge web and ecosystem of stakeholders involved, which is not at one level we are dealing with. Obviously, CHAI India acts as a non-profit organization supporting as an implementation partner for the whole program we are doing this. Then obviously there is a huge role of the government, the Ministry of Health, which plays into this, which is how this whole program is mandated through. We have the Central TB Division, which stands as the apex body who drives this program. If I look at in terms of the stakeholder, yes, our end goal is the beneficiary, which is the key stakeholder in this process. Then we have the field team, which I mentioned, who sets up your camp. The field obviously plays a vital role in doing day-to-day activities and setting up these health camps, radiographer, community mobilizer, and a district supervisor. So this is at a district level. Then we also have the NTP staff, which is your National TB Elimination Program, which has been devised under National Strategic Plan of 2025, which is a government initiated program to end tuberculosis by 2025. So under that, we have the NTP staff, which is mandated to support us for the different programs and the operations we are doing. So especially the NTP staff, you have your lab technician, you have your treatment supervisor. They play an integral role in terms of sputum collection, sputum testing, taking the samples from the camp to the testing facilities, and making sure that the process post the camp is followed, which is post-camp follow-up, putting the patient on treatment and registering the patient on the national dashboard, which is called NICSHE in India. Apart from that, we have the general health system, which again plays very integral role because setting up the camp, conducting multiple tests, and making sure that we're able to manage such a huge crowd, we need a lot of support from the health system in bringing the basic NCD tests. So we have someone called Asha, which is basically a health supervisor. So these women play a critical role in driving the health system, public health system in India. So Ashas we have, then we have nurses, then we have TB champions, then we have health volunteers. So these are like different stakeholders coming and aiding and giving their support from the general health system. And they play an integral role in setting up the camp, providing basic tests. So yeah, so in terms of these stakeholders, Shashwat, if you want to add, if I'm missing out on any specific ones.
Yeah, so across all 9 states, there will be a variation to these, but in essence, these are the core ones. In some states, we often find that there are other CSOs and NGOs that do partner, largely because they already have grassroots presence, and that's essentially what the field team tries to piggyback on. But in a sense, you need everyone who is highly acceptable to the community. That I believe remains the mantra there. be it your frontline worker, Sanya mentioned, in Asha, your AN, your Anganwadi, and that's like the known troika of rural community health service delivery, right? Triple A. In addition, anybody who has that kind of traction, that agency, and that confidence measure with the community, and pretty much the success to implementation lies there. And we've seen this fairly obvious, where we've not had good outcomes if these pieces did not fall into place. While we do have proxy indicators of both process and outputs to measure these, it's quite apparent that wherever you don't have that strong foot in the community, these don't work. So yeah, my short answer being there are variations to this, but broadly, yeah, these are the most critical stakeholders.
I want to come back to the way in which, like, AI kind of intersects with different parts of the stakeholders, but I want to go to Fadila, because Fadila, you are in a very different context. You're in Kenya with very unique healthcare challenges, but you're also a practitioner. You're a doctor by training, and you're currently practicing doctor in a hospital. Tell us a little bit about how you are seeing AI transform the medical health space in the Kenyan context. And you're muted, by the way, so.
Can you guys hear me?
Yes.
Okay, so I think the main thing that I can say about AI and basically just technology is the introduction of the electronic medical information system, or the medical services, where you have everything sort of online in most hospitals, at least private hospitals in Nairobi, as well as some missionary hospitals outside of Nairobi. So there's a bit of pushback in some hospitals because some consultants are really old and they're used to writing on paper. So getting them to kind of convert them into technology and typing their notes, some have experienced a bit of a challenge. But the hospitals in which these electronic medical systems are up and running and being used by most health professionals has really revolutionized healthcare in Kenya, because number one, there's a lot of the time between services. So if, for example, you're sick, and of course, if you have whatever symptom, you need to be taken to the lab, and the lab is going to take your blood sample or whatever sample, and then they'll send you back with a report to your doctor. If it's an electronic medical system, by the time the results are out, you don't have to wait at the lab. You can go home, or you can go somewhere else if you need to do like an x-ray or something like that, and the doctor who you were with initially will see it's updated on the same results page in the system. So that's really important. I think there are still a lot of gaps to fill. This electronic medical system, I think, is not more than 15 years old, so it's still very new. There's a lot of data science that you can use, data visualization tools. You can really and there are also a lot of like AI input things that you can actually say, okay, this patient has, like, for example, we're checking if they have an infection in their blood. Why don't we also check it in their urine and their stool? Suggestions that AI can give based on the history that you've put in on the system that currently is not there. I think some of the main challenge, building up on Shashwat's point, that AI in healthcare has faced is the concept of ethics. How ethical is it to share someone's disease and disease patterns with the rest of the world? And I think that's been the major drawback, because from there, you really can't build predictive models if you don't have a good data set. So I think more research still needs to be done on that aspect. In Kenya, at least, some of the things that I've seen in terms of AI models is the ECG machine that we use tends to give you what rhythm is wrong. So because they've analyzed multiple rhythms and they've worked with cardiologists, they've been able to come up with, for example, if there's a shortened interval compared to the normal ECG, or if one of the waves is higher than the other, you can quickly determine, even if you're a younger doctor or you're a nurse or you're a nursing student in teaching hospitals, once the ECG strip is out, the information up there by the AI model will kind of guide you towards making a diagnosis quickly and recognizing like a myocardial infarction, which is a heart attack. So it's really been helpful in the emergency department and emergency setup, but I still think there's a lot to do. In terms of the public health sector, currently we have a primary healthcare model for detecting disease in communities, which looks at community health workers who are just trained, I think, for 3 months and taken to communities to do basic things like blood pressure monitoring, glucose monitoring, and some of them may be able to give like drugs, like basic drugs like paracetamol to communities, and then now refer them to a level 2 facility, which is like a dispensary or a chemist. So this really hasn't worked out so well because most of these people haven't been trained on how to use these machines. So they're not able to detect the disease as early as they should. So there's still a bit to do there. And I think a lot of people aren't talking about the role of AI, for example, in making medical education easier for health practitioners. There currently, I think there's UpToDate, which is a software that an application and a software that most health professionals use. It's very detailed, and I think there needs to be more in terms of giving sort of like a pathway, like a flow chart for people who are not as skilled as medical doctors, because we do work with clinical officers who are right below medical doctors, and we do work with nurses. We do work a lot in Kenya. Most of the manpower is from students because many hospitals are teaching hospitals, and the community health workers who are not really qualified health professionals. So that's, I think, would build up on Shashwat's point again on health, on trying to build up that manpower and skill, because you can't really expect AI to solve your problems. You still have to have good data for you to be able to use it to be able to answer some of your questions. Yeah, so that's been sort of the challenges here. Like Abhilash, you mentioned, many people don't come to hospital when the symptoms first start. So there are some applications which have been developed in Kenya, like Beyond 8. There's Ponea Health, which I think, unfortunately, because of stakeholders, it is now no longer there. But those were electronic softwares, or let me say websites, which were offering telemedicine and e-medicine, where you could call a practitioner or be able to get them online and have your situation sorted out without actually having to go to the hospital, which number one saves a lot on time, and number two saves a lot on cost, because the amount of money that you pay for these teleservices are a fraction of the cost of what you'd pay in if you were to go to a hospital. One of the challenges that I think this poses, especially in pharmacies and online pharmacy services, is the misuse of drugs. In Kenya, you don't need antibiotics with a prescription. You can buy antibiotics without a prescription. So there's a lot of antibiotic use for basic common colds. You'll find patients are not responding and resistant to broad spectrum antibiotics like Augmentin, because they've used it before for flus and they've not used it correctly. Another thing is forging of prescriptions. You can get prescriptions online and forge them, or use AI to forge the prescriptions and use them to send through these telepharmaceutical services like MyDawa. There are so many, by the way. So I think this is one of the new challenges that we're facing with AI in healthcare in Kenya, which I don't think is being discussed a lot because it's not really spotlighted as much. People don't know this is fraud. Yeah.
So yeah, thank you so much for that context, and for the purpose of those of the folks who are listening who might not work in public health or in the healthcare sector. there's something that I think most of us forget is healthcare is not about doctors, right? There's an entire value chain of nurses, of ASHA workers in India who are public health workers in India, pharmacists, and there's a lot of value and by the way, there's capacity constraints in all these specific other domains. And capacity constraints, not just in terms of number of people, but the kind of training that they've had access to, right? And the potential of AI in being able to aid and augment capabilities of people who are outside of the doctor's office, I think is something that we are just starting to maybe think about. And what Chai has been doing is a great example of how AI can add and augment human capacity and human capital outside of the doctor's office, right? And that's a really interesting kind of use case. The other thing that Fadila mentioned, which I'm also curious to hear in the Indian context, is this first mile data problem, right? We talk about AI, there's a lot of conversation and hype around AI. AI can work really well when you have or cannot work really well when your basic data infrastructure does not exist. And in many parts of the world, that basic data infrastructure, right, and having an electronic medical record of an individual patient over an extended period of time, so that you can have, say, an AI agent detect like anomalies and be able to kind of, point out these anomalies, that cannot exist until that basic data infrastructure exists. And my kind of fear is that the focus on large language models or foundation models, etc., is kind of missing out on the lack of investments in these basic first mile data infrastructure that needs to be built up so that you can have your foundation models really be activated in the future. And I'm curious to hear from you, Shashwat, about whether this is a problem that really exists, or if you see that this is something that people worry about in the sector.
So my quick answer is depends on who's asking and depends on who's telling you. But to take a more optimistic view to this, I think a lot has changed in India over the last 5 years, and if I may be so bold enough to say this, we went through a whole churn of moving to a lot of digitization of records across the spectrum. One of the prime beneficiaries for this has been health as a sector, which means when all of the vaccination drives were happening in India, what was happening at the back end of the health stacks was everybody was being assigned a unique health ID, just that people didn't know about it. And with the power of unique identifiers that what we call Aadhaar has been pretty much rolled off around the country successfully, there is a digital footprint for most of us for a health record purpose. And I think that's a good start for us, and that's something I'm going to take an optimistic view to this, because there's no point for us to be in this realm and doing all of this AI and all of this if we're not really convinced that this is going to just be a flash in the pan, so to say, right? And therefore, we're seeing great benefits of this, Abhilash. And if you will just indulge me for a few more minutes, what we're seeing is that a lot of providers exist within the country, private as well as public enterprises are also getting, but definitely private are there already. There's a lot of PPP, public-private models that have been created where you're looking to look at part of the problem being solved by the government, and the other part, which is more service delivery, more cost effectiveness, being taken up by the private sector. So we're seeing a lot of these PPPs come into being, and the whole Aadhaar story was one such example. And we are seeing these evolve into more things, including AI. and therefore government also has a viewpoint of why not create something which is a social good, but if somebody else can do a better job of it, why really? Then of course there are different nuances to this across even across the public health system, but nonetheless this is a generally good accepted principle by most standards in the last decade, till over 5-6 years that I've been seeing. So if one were to introduce tech, big data, even your AIs to the tune of any models, now is the perfect time. 5 years ago, it would have been a disaster, right? And 5 years later, we would have missed the bus. And this is largely because of the population we have to deal with. So I think this is a sweet spot, and it's a good time to be doing whatever you do within the domain, because there are other ecosystem variables that allow you to do things better, be it on the tech side, be it cloud services, be it just the cost of data in the country, right? So these are very good enablers for all of these pieces to happen. And I guess time will tell how these pan out. But yeah,
So can I interject and can I ask one more? So I mean, I think what you mentioned in terms of cost of data going, the data collection going down, the infrastructure going down is incredible. What I think a lot of people also miss out on, especially outside of India, is that the regulatory framework is a lot more friendly for public health innovation than, say, in the United States, right? I mean, the regulatory framework in the United States has been kind of very conservative, for the lack of a better word, right? So it is very much like there's a lot of regulatory layers that allow, and which is good for things like protecting patient privacy, but can also become bottlenecks for innovation because you don't have access to those data sets. Whereas I think the Indian regulatory framework, people complain about, oh, is it really protecting patient privacy? Is the data safe? But on the flip side, is also creating a kind of data layer and a data framework that is much more amenable to innovation than, say, in the UK or in the US. I'm wondering if you can speak to that a little bit.
Yeah, that's pretty relevant, and more recently, so the Data Privacy Act that was amended and passed in Parliament was withdrawn very recently, largely because they believed it needed to be strengthened. So I think from a government standpoint, I think those things have been looked at under a microscope. It's almost become a mandate where does your data reside, who is handling it, where are the servers, etc. And I think those checks and balances, I think India, because it started off a little late, had the liberty and the privilege to learn from others' mistakes around the other developing countries, where there was a lot of data breach and privacy really took a bad hit. And of course, we can have multiple debates on how private is privacy really. But to that end, I think I'll again take an optimistic view to this, because there is no way to succeed in the impact sector if you're going to create a lot of these large ecosystem variables as a cynic. And therefore, data protection and policy and privacy are better safeguarded than before, for sure. And I guess what the government is also doing is adding another layer of this, and I think we all will see this in another 12 to 16 months, where a larger rollout of unique health identifiers should be in a critical mass, and probably one of the largest of its kind in the world. The idea is to create network of networks, so to say, and create primary care linkages to tertiary care. What that also allows is help in more effective referral systems, reducing out of pocket and all of those social determinants get affected there. But at the same time, also from a public policy lens, help the government plan better, right? All of this data, if sitting in somebody's system, is of no use if it's just pure data. At a policy level, it's what we really want to do. And of course, I think there'll be enough debates on how does one want to use it. But if you were to again look at it, what it's ideally supposed to be done with, you can target better. Epidemiologically, you can be smarter about how you look at public health at the national level. And these are the data structures which will help you get there. It will definitely reduce public expenditure because you know exactly where the targeted money is going. It will also help bring more accountability in terms of drugs and diagnostics. And thirdly, it will also allow for social welfare schemes to be targeted directly to the accounts of the beneficiaries. So it has a multi-pronged approach, but definitely I think we're in a very sweet spot for India in terms of how tech is getting into a lot of social good domains, and health is just one of them. I mean, we can look at AI for education, you can look at AI for livelihoods. You've got how geospatial AI models are working for weather patterns, crop cycling, etc. I mean, it just goes on and on, right? So I think we're getting there, and government's doing a good job with integrating systems. I think that's the big one. Thank you.
Yeah, thank you so much for that. And thank you for also flagging the fact that, conversations about privacy are conversations that require a certain trade-off, right? I mean, how we need to talk about trade-offs between privacy and what data access to specific types of stakeholders can enable. Whereas I think, oftentimes in the West, the conversations about privacy tend to be very kind of unidimensional, like sort of saying privacy is the only thing that matters. And the government should not have access to patient data at all. Whereas in a massive country like India, with like lots of challenges in managing, say, epidemics, you need to have a question around trade-offs and at what layer you want to have that privacy come in. So I appreciate you kind of flagging that. I want to open up the questions to the larger audience. This has been a fascinating discussion in understanding how AI is being used, and I hope we can have this group come back again, maybe in 6 months and a year. It's just such a rapidly evolving field that things are going to change quite a bit in the next year, and so it'd be great to be able to talk to all of you in a year's time and see how things are changing in your specific domains.